thank you for attending. My name is Scott Martin. I am the president of Catalyst Solutions. On behalf of Catalyst Solutions and InfoMC, we'd like to welcome you to our webinar today, CalAIM 6-month checkup, successes and challenges of enhanced care management and community support and implementation. Thank you for joining us. Thank you for taking time out of your busy days to listen to what we're going to be talking about today. As a matter of housekeeping, this webinar is being recorded and the recording will be shared. Questions can be submitted at any time using the Zoom Q&A buttons at the bottom of your screen. These questions will be addressed at the end of the presentation. We are nearly 6 months into the launch of the CalAIM initiative. And we're welcoming you to hear the perspectives from healthcare plan and CBO leaders on the successes and failures of the ECM and CS implementations. This webinar will be a moderated discussion among healthcare plan and CBO leaders from the Health Plan of San Mateo and Pacific Clinics. These leaders will speak to the lessons learned around how CBOs can best prepare for their roles in performing new functions such as revenue cycle management, encounter reporting, and ideas that go beyond the initial implementation, such as using evidence-based programs and other innovations in the human services setting. With that said, it is my pleasure today to welcome the speakers. First is Dr. Eleanor Castillo Sumi, Senior Vice President of Strategy, Innovations, and Growth at Pacific Clinics. In this capacity, Dr. Castillo Sumi is responsible for developing new partnerships and programs to support the agency's growth and commitment to communities across the state. Dr. Castillo Sumi is a licensed psychologist and has published articles in the American Journal of Orthopsychiatry, among other publications. Additionally, she has spoken at various conferences, including Open Minds and California Alliance for Children and Family Services. She is a member of the Research and Evaluation Subcommittee for California's Mental Health Services Oversight and Accountability Commission. Dr. Castillo Sumi is a board-certified behavioral analyst doctoral and has a PhD in clinical psychology from Pacific Graduate School of Psychology at Palo Alto University, where she was awarded Dissertation of the Year. We also have with us today Dr. Chris Esguara, Chief Medical Officer at the Health Plan of San Mateo. Dr. Esguara has led system transformation, program evolution, as well as public and private partnerships. These engagements have led to outcomes that meet the quadruple aim of improving health, cost effectiveness, enhancing patient experience, and supporting provider well-being. He has led significant efforts around the integration of care and services for a variety of populations, holistically addressing social determinants of health and healthcare delivery, and helping people remain and age in the community with appropriate long-term services and support. Most recently, Dr. Esguara served on the National Academy of Science, Engineering, and Medicine committee that published Integrating Social Needs Care into the Delivery of Healthcare to Improve the Nation's Health. It's also my pleasure to introduce today's moderator, Mark Refowitz, the former director and former chairman of the board of directors at the County of Orange Healthcare Agency and CalOptima. Mark retired in April of 2017, but his career spanned more than 40 years in a variety of executive management and clinical leadership positions in the public sector, in healthcare with the state and county government, as well as the private sector. These roles included the director of behavioral health in Orange County, mental health director for the County of San Diego, Senior Vice President of Development for Health Inc. in Costa Mesa, California, Chief Clinical Officer with Community Care Behavioral Health Organization in Pittsburgh, Pennsylvania, Assistant Commissioner for Managed Care with Massachusetts Department of Mental Health in Boston, Senior Administrator of the Department of Mental Health in the Office of the Federal Receiver for the District of Columbia. And Mark was a member of the CalOptima Board of Directors and the Children and Families Commission, First Five Commission of Orange County. With that said, Mark, I'm going to pass it over to you.
Thank you, Scott, and hello, everyone. I just wanted to give you a snapshot of who has said they were going to attend today. As you can, we have about 150 participants. They represent health plans, FQHCs, community-based organizations, county behavioral health, medical groups, hospital groups, consulting organizations, and and advocacy organizations. We have clinicians, administrators, IT people, and data analytics folks, and advocates. So let's get started. Let's dive in with our first question. How would you, Chris and Eleanor, how would you describe the transition from whole person care and the health home pilot programs to CalAIM, enhanced care management and community supports? And what were some of the issues and challenges your organization faced during this phase?
Well, Eleanor definitely will chime in. I think I'll speak from the perspective of just overall, and then based on sort of whether you were in a county that was whole person care or actually had the health homes pilot. But the bottom line was that things were rushed and things were rough, specifically from the perspective of community-based organizations, in the sense that whole person care was a wholly different pilot and structure financially, in terms of how it worked in a county setting. Whereas health homes actually did push and looked a little bit more like what we have with CalAIM. And so there was a little bit more practice there for those counties that did go live in health plans and community-based organizations with health homes. And so there was just a little bit much more familiarity, and it looked a little bit smoother. But the bottom line is that given the rushed nature of how things played out with DHCS, Department of Healthcare Services, in providing the structure and the roadmap to going live, and therefore the health plans actually having to submit things and get things approved and all of that, there really wasn't that much time spent to be thinking about the implementation and thinking about it really from the community-based organization perspective. And just the amount of work it takes to actually bring these pieces up to speed, frankly. And so, I mean, turn it over to Eleanor to talk about that, but also really just, you want to underline that the implementation aspect.
Thanks, Chris. And I completely underscore, the importance of implementation. From the provider standpoint, Pacific Clinics over 2 years ago, I guess you would consider was an early adopter of the health home programs. We saw this as an opportunity to, if you will, prepare ourselves for what was coming forward with CalAIM. And there are a number of different CBOs like Pacific Clinics who currently contract primarily with counties that are currently in the exploration stage. So if we're talking about implementation science, there are a number of different phases, and within those phases, there are a number of different drivers to assist with implementation. While we knew that the change was coming, we adopted and therefore made an explicit decision to move forward with changing our infrastructure to be able to work within the space of the health plans. So for CBOs, this is huge. Pacific Clinics is an organization that's over 150 years old. So there's a whole set of culture that's associated with working with county mental health plans. That change, and that's changing for all these CBOs. So the next stage after you explore and adopt is then program installation. What are the structures that need to change? What are the competencies that your staff need to have to operate successfully in this new world? And for us, even though we had that opportunity to, if you will, pilot those things through health homes, it was still a rough change for us. Our contracts ended 12/31. Contracts were supposed to be in place by 1/1. And none of that, that's an example of something that wasn't in place. So we continued to serve those that were grandfathered into the enhanced care management program while we were still trying to build, or if you will, continue to do what we needed to do in the program installation stage to be ready for this initial installation. So, and I would say we're still there. We're still trying to build all the things that we need to be successful in this new space.
Yeah, I definitely want to underline that, Eleanor, because I think what we saw at Health Plan and Mateo was a heroic effort between our plan staff and our partners to get over the finish line of getting the contracts in place, to get going and get understanding the list from whole person care to switch over to enhanced case management. And I think from the perspective then of an implementation science framework is that ideally implementations like this shouldn't have to be heroic, and that there is a conscientious path that we set. And so what does that mean? And we'll get to this a little bit later, but that there are implications to, well, what happened January 1st it's not the last implementation. We have other populations of focus to consider. And actually as plans, every 6 months we can choose to then include new community supports or expand in whatever ways. And so there are opportunities there then to take what we have learned from the January 1st start of, frankly, it's going live. And I think that's the other piece of making, it wasn't necessarily as clear as it could have been from a state perspective, but I think that's the opportunity that can happen and be forged more locally of what are our expectations come a specific deadline date. And I think making that clear as well, I think also probably takes a lot of pressure off, or at least makes it clear to the parties involved. One of the things I'm definitely mindful of, and I know we have been mindful of at HPSM, is really the power dynamics of all of a sudden now community-based organizations and county organizations with whom we partner may not necessarily have worked with in a plan's structure, and with not necessarily just the contracting, but the payment models, or as well as the
Credentialing.
the credentialing, claims, all of those operational pieces. And it's this idea of how then do we help and support bringing that in. And so thinking about it as a go forward, what are the structures then that could be useful to support? And in a way, sort of technical assistance now is a little too late. That would have been helpful before. And I know some organizations, like for example, California Food as Medicine Coalition did do technical assistance to the medically tailored meal organizations prior to all of this starting. However, that may not necessarily have been the case for other organizations. And understanding that, for example, for a small community-based organization, just the whole idea of getting up to speed with HIPAA and being able to bring up your security privacy levels that would blow your IT budget for the year, for example. And I think it's just understanding that and what would be those pathways. And because from a plan perspective, I think we needed to be, and I know we tried to be conscientious in understanding that we cannot necessarily impose standards that we normally would impose, say, to a primary care office that wants to be in network, all of a sudden to a community-based organization that may not necessarily have worked with a health plan before.
So underscoring again, so organizations have to go through this, transformation, if you will. But that transformation is not just within the organization, right? And as Chris is, I think, describing here, there's a between the entities and the work that needs to happen between a CBO, for example, and a health plan or the county. So we're talking about program installation on multiple levels.
Many waivered programs sometimes go through a readiness review. Did you have the opportunity to go through a readiness review with any of the health plans in the counties that you're in, that you contracted with, and what was that experience like, if you did have it?
From the CBO perspective, there wasn't a formal readiness review. As an agency, there were several assessments from Open Minds that is available for CBOs to actually go through those different reviews that look at your workforce, looks at your IT system from the EHR as well as from the revenue cycle management perspective. So we made the choice to go through that assessment. But I would imagine if you didn't know about those resources, then you wouldn't know that that's an option to you. But again, that's a choice that we made, and I would say is a critical part of getting ready. Having that baseline, knowing what targets you need to have in place, identifying the areas for which you need to improve, and targeting your efforts. I think those assessments would be really helpful.
Yeah, very much agree. And I think, part of the nature then in the rollout, thinking about this systematically from a statewide perspective is how, as a part of a go forward, and clearly this gets to the deficiency of the implementation, is how do we actually make that as a standard? Because we'll have other rollouts with populations of focus, right? And how is it that there is a way to incentivize and provide that support, technical assistance to actually go through that kind of assessment? Eleanor alluded to what is the transformation component. Well, I think one of the other transformation pieces is, for example, just for a CBO that perhaps had worked with contracts that were more of a cost basis perspective, right? The cost of which I'm providing something, and that's how I'm going to get paid. For enhanced case management services, you are now paid on a per engaged member per month. Completely different. The math works out very, very differently. You're now having to think in a different way altogether. That's a transformation in and of itself, and that's just about one. And then we need to be thinking about data systems and the interaction with the health plans. What are the workflows and processes with the plans overall? I think, whereas I will say that certain plans, certain counties, we made it work given those strong partnerships that we've had already. That's not necessarily the case if you look at it more from a statewide perspective. And really, when we think about it from that kind of inconsistency, there's an opportunity then from that at the DHCS level to then be able to say, these are the best practices that will be really helpful once we start thinking about going live. And going live is not that far for the next population of focus, which is July. For all of our other populations of focus, I think there's a path there to be thinking about how do we address what has already happened and the challenges of what has already happened.
And you have, again, different CBOs in different places, right, of implementation. You have those that are still just exploring all this. And so I think part of their, the exploration should be this assessment to say, can they go there? As opposed to going there and then figuring out, this is just very difficult. As a large organization, we have the ability to be able to put in resources, but not all organizations are the same. So, the ones that are primarily that would be at risk without support are your ethnic specific CBOs, who are critical in this whole system of care, but might not have the resources to be able to go through this assessment phase, if you will, to determine, what they need to do to be able to operate in this new landscape.
And I'll say similarly on the plan side, there is a bit of readiness work. I think it was very easy to really focus on all of get the contracts in, get your network in, to submit all of those things to DHCS to check the box because there's the compliance component. And also, but then how is it that we're now thinking of, well, okay, who is our population? How are we going to do referral workflows? All of those pieces, that other part of the process components of this implementation. And I bring this up largely because I work in support a number of other CBOs. One of the common themes I'm hearing is that that for some in some other counties is that they're not necessarily getting the referrals yet. Then this is in the world of community supports, let alone thinking about enhanced care management, but just thinking community supports. And I think then it's back to from a systematic perspective, how is it that there's a framework that every party that's going to be coming together to accomplish this great thing, which is CalAIM, how is it that we start thinking about all of the pieces that we need to be doing in order to actually do this well?
And there's huge consequences. For us as a CBO, we took our directive as to be ready to provide services January 1st or January 2nd, the day after New Year's. And so we hired, we hired for, for capacity reasons, and we need to provide those capacity reports. And we hired to be able to do that. And, it's now May and we have staff in counties ready to provide services. But, the referrals aren't there. That would be a huge fiscal burden on a lot of organizations.
I think it would be fair to say that our friends and partners at DHCS understand the landscape of California. There's a saying in California, if you've seen one county, you've seen one county, and there's 58 plus the city of Berkeley and Tri-Cities that all have to figure this out and move forward. And I also believe that from their perspective, it was going to start slow, even though they had bold aspirations of getting out of the gate, and that people were going to build on the previous pilots, whole person care and the home health pilot at the very beginning. And hopefully, as we've talked about implementation science, the lessons learned, as Chris said, we have many more populations to bring on, that things will improve. And I do know that many of the health plans have posted lots of material on their websites about how to do community engagement and explaining CalAIM's, goals and aspirations. So there was material there. I appreciate your perspectives on this very first question. And I think it would be fair to say that CalAIM really is a very bold partnership between the state of California, federal government, CMS, the communities of California, the counties of California, and really is an opportunity to invest in results and to really solve these very difficult issues, rather than just trying to manage them. And with that, I think we should move on to the second question, which is, what outcomes have you seen so far, and successes or challenges?
I'll speak to one. We went live. We got started. That's good. We also got started. We were able to continue some of the work that was already occurring, and speaking to San Mateo in particular, and transition, and also from whole person care to enhanced case management. For some of the specific community supports that we were already doing, and Health Plan and CBO has a history of doing community supports, housing navigation, transitions from nursing, all these things for years. We just put it in our admin budget. Now it's actually just being recognized. And so that's great. And so to be able then to actually continue that, knowing that we can enhance it and really move it, which is great. But if I look at some of the newer community supports, not much utilization just yet. And that's going to be the, how do we continue to start to emphasize these pieces? But at the same time, there's still such this focus of there's that continuation. Can we get ECM going? Now, understanding that's how it's worked so far, given the intensity of the work and partnerships that we had to do prior to getting started. Now, I understand too, and Eleanor will definitely expand on this, that there are some other counties where contracts haven't been done yet, or processes haven't been figured out just yet. And so I think if anything, initially, the thought was, okay, maybe we would be able to get things in order by the first quarter. It's May now, and I think there's still a bit of a struggle. And I think part of that means then what is the support needed, or do we need to be thinking about to actually get this going in an equitable way throughout the state, so that it's not so dependent on which county can make it work versus other counties where it struggles?
Yeah, I would definitely say, I agree, Chris. I mean, we went live for good or for bad or worse, right? But we now have conversations with different partners that we never had prior, to Health Homes and prior to CalAIM. I think there's a different level of appreciation for what this means for community-based organization. But again, I just want to underscore, Pacific Clinics is a large behavioral health organization that has resources to be able to do this. it's more risky for organizations that do not have, that kind of resources. And so we feel like it's our responsibility as a large organization to also help, be a partner in trying to figure this out for the system. We talked about an assessment for CBOs, but I think there also needs to be assessments for, for the counties and the relationships within the counties, because that definitely trickles down. We are in multiple counties, and I can underscore, our experiences in each county is very different. The county in which we started Health Home is far more advanced because of the previous relationship that we've had. But it's, again, not every organization and not every county has gone through that. So I think, going back to that assessment, if you will, and monitoring progress. So, just the process of implementation, I think is a needed part in the system. I think we all have very different perspective of how well the implementation has gone so far. But I would say from the CBO's perspective, this payment reform is a huge concern, because there's not a whole lot of conversation, or at least from the CBO's perspective, about what this will mean and the implications to the CBOs who've been operating under a certain framework and payment structure for decades. And this is, right in front of us. And, again, if we were to talk about implementation science, this program installation stage, to really having an adequate program installation phase to really prepare and minimize the unintended consequences of this change is really critical.
Well, I mean, and Eleanor, I'll have a question for you, but I wanted to really underline the payment model change in that piece. One of the interesting things, if I'm going to compare and contrast, so North Carolina also did a huge transformation to its Medicaid program, and recognizing that we are just, as a country, we are not going to be spending any extra money on social services compared to other developed nations. That's just who we are here in the US, but instead we are going to invest healthcare dollars, hopefully, to more social services that will improve the health of our of people in the US. Great. One of the things, though, that did occur in North Carolina is there was quite a long stakeholder process and thoughtfulness on just even the payment models for the social services and development of the fee schedule. And one of the resounding themes around that, the whole discussion, was to be thinking about, if not value-based now, what is the path to something that's value-based? Understanding that just by using that term, that payment is really more about creativity and getting the outcomes. And that was quite a process. Was fortunate to be able to help and participate in that whole piece. I don't recall seeing that necessarily as a discussion here. And I know one of my concerns has been that we don't necessarily repeat the challenges and unfortunate things that have happened in primary care, in the health plan world, that we've done in just the fee-for-service model. Now, it's great that with enhanced case management, that's per member per month, but some of the community supports are more of a fee-for-service in nature. And I've definitely seen that in some interesting contracts where it's like, whereas the guidance is much more of a value-based or a bundle or something like that, that it actually went more to a fee-for-service. So, but that's still a change. And so I think, Eleanor, I'm wondering what would be helpful as a go forward that to really support and be thinking about, well, in terms of a revenue perspective for CBOs, how to adapt to these different payment models.
Yeah, basic things, and it's not so basic, because if you don't have the right technology to do this, then it might sound easy, but just knowing your cost, and knowing your cost is not just your staffing costs. It's all the associated supports, quality assurance, credentialing, to be successful in this business, right? Or the way we're changing to do business. So things like, again, just knowing your costs, do you have the right technology to even the organization and cultural change that needs to happen, being cognizant of utilization, even understanding what utilization means, being able to stratify your population, I mean, just understanding that within your organization is huge. So I think, again, technical assistance, oftentimes CBOs are left out there. I mean, there are tools and, it's on you to go figure it out. But having the coaching and the technical assistance to really look at that, I think would be important.
Did you, either of you have any particular insights into working, for example, with, one of the priority populations, working with the correctional settings to help ease the transition back of those future members of the health plans and potential members of the CalAIM ECM initiative?
Yeah, so let's talk about the transition from incarceration back to the community, and that is, for criminal justice involved individuals as a population of focus. So I think the thing to remember or recognize for when we're talking about supporting that population, especially in that transition period, it's not just the plans and the CBOs. One of the key pieces that we all have to remember is that in California, if you're incarcerated, you go to jail, you lose Medi-Cal automatically, bottom line. And that when you're released, and when someone is released, you're released at midnight, the day you're supposed to be released, not when everything's closed, you don't have Medi-Cal. And you're left to essentially try to figure out then how to do that, and how does one get back on Medi-Cal. It's not necessarily through the health plans. It's not necessarily through the CBOs. It's through the county human services agencies or equivalent to do that. And so that's another partner that needs to be involved. And how do we start thinking about that process, that kind of in-reach, so that we are prepared? Because again, from just the criminal justice system perspective, they're not gonna, and there's a rights component. They're not gonna hold that person to the morning when business hours are available. They're gonna release them at midnight. So there's all these implications, and I've way back when I used to be a covering psychiatrist at a local county jail. I mean, we had issues of what pharmacy is open at midnight for our folks that are being released that need to be having medication. So we would give a supply, but what's an appropriate supply? So these are going to be the challenges to think through, even before you start thinking about what the services are.
Chris, I raised that question just because it was a specific example. I know that many of the listeners want to know what's worked well or not worked well with engagement, and outreach, et cetera. But it's time for us. I think we should transition to the next question. And I think that this will give you and Eleanor a wide swath to enter into here. So if you had a magic wand and 3 wishes, and it's hard to limit it sometimes to just 3 wishes, what would they be for your program?
Well, I think we're both resounding yes on the attention to the need for implementation pathways. Of which, implementation science, it's there. I mean, we can all Google it and figure out all the steps and lay it out. That's a whole webinar in and of itself. However, I think making sure that there's time and therefore stakeholder discussions to actually do that, because we have a lot of other populations of focus to go live. So that's one. I think the other piece is a technical assistance arm. Eleanor, I'm not fully aware of any statewide version of that necessarily. But I think that would be very, very helpful on really helping the CBOs, but also helping the plans on some of the operational pieces, as I'm sure the CBOs can definitely give that feedback to say, where is it that we're not doing so well? And what is it that we need to improve? So I'll definitely start there.
No, I completely agree, Chris. Just being mindful of implementation science and implementation drivers, and really applying that in the implementation of, future population, or for organizations who have not yet, started with CalAIM, but are considering it. So, I think, that is really important. And then when we say technical assistance, it's more than just training. So this is not here's a webinar on this, go forth, good luck. We hope and pray you do well. But technical assistance on getting into a baseline measure of where we are and where we need to be, we being an organization, we being the system, the partnership within the county and the partnership with the state. And what is it that we need to be able to be successful? And this cannot be left to just CBOs or other organizations to figure this out, because it's a lot. And for organizations, they're still doing business. We're still doing business as usual. So to learn to have the resources again that can focus on just transition is again another layer of resources, another layer of skill sets that's needed to help an organization transform. So I definitely agree with the technical assistance, and perhaps even using some of the incentive payment plan monies to help organizations along this way, would be a good use. I mean, it's interesting to put together a plan and apply. And quite honestly, again, we're an organization that has been doing this for the last 2 years. We've got we've had an EHR since 2000, so that's not new for us. But it's still figuring out. I mean, you have CBOs trying to figure out what technology, what does the data infrastructure need to look like? Because I mean, for us, again, we went through this, so we have a picture of that. But for an organization that has never done this, they don't know what to ask for on that IPP application. So again, technical assistance on multiple fronts and multiple levels is really important.
Again, this is your magic wand. I'm surprised that no one jumped in and basically talked about the problem with affordable housing in California. If you think back to Malcolm Gladwell published the article about $1 Billion Murray back in 2006 about Murray, who lived in Nevada. Housing was a significant issue, and it was also a focus for people in whole person care. So it's kind of interesting that nobody took a wish, and wanted to talk a little bit about affordable housing.
Well, that's because I think we all know how complicated that issue is.
Yeah.
And it's not just something in healthcare. It's not just something that happens with CBOs, and there's a whole policy piece, and I'm sure we can detract from that. One other actually sort of nice to have wish that would be really cool to see. I'm curious your thoughts on this, Eleanor, too, is a forum wherein plans and the CBOs interact to really start addressing what will be the common things of what do we do when. So Christopher Zubiate pointed out, what out of county placements, when someone loses their Medi-Cal for whatever reason, what do we do when? And frankly, that applies statewide, and that becomes operational pieces. So, instead of us saying yay, we went live, but then there are all these other pieces from a process perspective that just will happen. Now, from the plan perspective, yeah, we deal with that pretty regularly, but from a CBO perspective, you'll see it as a disjointed effort around case management, or all of a sudden you're not getting paid, but yet you're actually still working with that client, or something to that effect. So how is it that we surface these things and essentially create that kind of partnership and working together as a forum? But with this as initial focus, I'm sure some other things productive can come out of that.
Yes, I mean, again, from the CBO perspective, we've been asking where can we give feedback? Because we certainly participate in many different webinars, many different forums to receive information, but the ability to give feedback, and not just give feedback, but really see, that the feedback is taken into consideration. I haven't found, and there might be a forum out there for that, but I haven't found such a forum. And we are on as many stakeholder mailing lists as possible.
So from both of your perspectives, what are the kinds of things that, again, might be needed so when each and every potential member of that, and member choice is still very important. What can be done that when when people are contacting them and trying to engage them either at FQHC or another community-based organization or out on the streets, that somehow they feel that you're their angel and you're giving them some hope, hope and aspiration that, you know, things will improve for them.
I'm sorry, Mark. So were you asking from the members' perspective?
Yeah, the members' perspective. How do we give them hope that, you know, their hopes and aspirations will be reachable?
You know, from the provider standpoint, you know, we have service principles that guide us around there, and you know, one of them is to do whatever it takes. And you know, CBOs will do whatever it takes. So no matter how difficult it is, they will try to figure it out. You know, they will go down whatever path they need to know of, use whatever resources they have, you know, with other sister organizations to figure things out. But I think, you know, inspiring hope is number one. And, you know, we hire staff that agree to or share the same service principles.
Yep, totally agree. And I think where from a structural perspective, the plans come in and how we support that, two major areas. One, the way in which we pay supports that kind of creativity. We know that engagement for in just engaging clients, members in general is a tough process, and that you have to be creative. It's not going to be just phone calls like ad nauseum, right? You're going to have to find ways to get through in the community, and it's not going to be just one meeting. It's going to be multiple discussions over time, because frankly, I mean, if I took that perspective of a member, it's really, who are you, stranger, and why are you talking to me? So it's, you know, it is an imposition, and how is it that you build that trust and over time in order then to see that, you know, to work towards change. And that's the motivational interviewing framework. That's an engagement framework altogether. The other aspect is really, as plans, is then how is it that we are able to share the data that we have, knowing at least the healthcare identifiable signals and behaviors that we have in our systems, whether it's, you know, information that, oh, they were able to see their primary care is this person, or their pharmacy is this, and they've actually last filled medications at this time, or they were last seen in an emergency room here, or whatever other information that we have that are then able to support that, so that the CBO is not necessarily going in blind, because we have that information. And so how do we make sure that is going through? What are the other technologies that we may have as a plan that we can share? So for example, you know, we have the notifications from, you know, when someone pops up in an emergency room, we have that as sort of real-time notifications. How do we share that, again, with the CBOs? And again, it's thinking about it from that perspective to really then empower our partners to be successful, but also knowing that success isn't going to be, you know, you talk to that member once and all of a sudden it's going to happen. No, we know that success takes time, and that could be as many, you know, could be multiple conversations, multiple engagements, especially for our more challenging populations.
It would be great to be, you know, financed for creativity. I mean, we have a drop-in center that's really based on motivational interviewing and recovery supports principles. And, you know, the idea there is, you know, it's this open center for TAY-age youth, transitional age youth. They can drop in, you know, they have resources there. They can use that opportunity to start building relationships. But you know what? We don't get paid for that. We don't get paid. Health plans don't pay us to create an environment where people feel welcome and they can build trust. And when they build trust and when they start to, you know, contemplate and then get ready to take action, they know we're there. So that's what we're investing in, is here, come into this open space, build a relationship. Meanwhile, you know, there's some washer and dryers here if you want to clean your clothes. There's some shower here. We have a small kitchen where you can, you know, cook a little bit, throw something in the microwave, and do some employment search while you're waiting for your dryers, you know, your clothes to get dried and your meal to, you know, be done in the microwave.
So I'm being very mindful of the of the time. This seems to be a good stopping point. I just want to do a very, very short recap of what I've heard. I'd have to turn it back over to Scott because we're going to try to get to some of the questions. This is a bold initiative. It was, in Chris's words, it was a little rough and rushed at the beginning. I like to say it's somewhat like building the airplane while you're flying it. And we need to learn as we go. I mean, that was really clear from both of you and from both of you also. Take this as an opportunity to build a learning community and work with all the communities under the purview or in the service area of a health plan. And so with that quick recap, I'm going to turn it back over to Scott.
Mark, thank you very much. So we have a number of questions that popped up over the course of the discussions. So some of them are things that we've touched on, but I want to actually take the question and forward it back to you to kind of hit on the specifics. So number one, what is working in terms of outreach and getting individuals from the WPC pilot engaged with the service providers? And there's a part two, what is resonating with the clients that are the strategies varying community by community?
Eleanor, I'll let you take this one to start.
Yes, so what is working in terms of outreach and getting individuals? Mark, I mean, you brought up the point of hope, and I think that's a really critical thing. When you get that first contact with people, whether it's by phone or going to their homes, or meeting them somewhere where they feel safe in the community, inspiring hope with that first visit is really critical, and that is, that's something that's universal between communities, or across counties, across communities. But there are different strategies, and I would say even with different age groups, the different strategies there. So it's not just with ethnic groups, but age, rural versus suburban, but working with people who really understand those communities and having them as part of our team is really important. So again, that's a selection piece. When you think about an implementation driver, and the competency that you need, the selection of your staff is, pretty critical.
And where the plans really help is, as we are assigning those members to the CBOs for enhanced case management services, we have the analytics tools to be able to say, hey, here are the characteristics of those members that we're sending over to you, to help you plan for this, to be able to think about your staffing patterns. We have that data from a demographic perspective, from the utilization of services or lack of perspective, and I think then, or even internally, of where have we tried to reach out from a case management perspective? Have we been successful? Have we not been successful? What has worked before? And so those are things that we readily can provide, and to varying degrees. And I think that's the key of how then do we think about that, standardizing it from a statewide perspective, because from a plan perspective, this is our population health management effort, and how we think about our membership overall, and that we're already working to stratify our population in some way or another, and we have that information. So that's where we can become partners to then help and really fuel that creativity by way of the data.
Yeah. And that would be amazing. Again, from the CBO perspective, we would love to have that data. And from the CBO perspective, we know our experience has been in the last 2 years that we can convert from 25% to 40% of members. And actually, there's some differences between health plans with our experience. For us, and then about 25% of the data, the information that we get, wrong numbers that don't work, that's about 25, that's pretty consistent, about 25% of our data. We know that we have to work hard to getting, the right information. But for us, we're more interested in not only who converts, but who doesn't and why, and is there a certain profile? Because then we can strategize more specifically, to reach out to those people. And, we hope that we can get there at some point. And that's part of, again, the data infrastructure that providers need to develop.
Yeah, I mean, I recall, I was with a different plan when we implemented the health homes program, and the state DHCS was targeting an initial engagement of a pretty high rate. It was in the double digits, definitely. And when you looked at other states that had implemented health homes, the first year engagement rate was pretty much, if not 1%, low single digits. And the reality is because this was just new. And people had to be creative, and people had to then figure out the data component, what was needed. Now, what was interesting in part of the rolling out was the financial model that we decided to take that kind of gets to Eleanor's point of financing the creativity. So typically, the payment model for health homes was once you have someone enrolled, you get paid. We actually chose a different route of saying, okay, sure, we'll pay that. We'll take some of that though, and actually for the entire list that we're going to give you, we're going to give you what essentially we're just called the engagement fee, because we know you're going to do a lot of work for free, and so we're going to need to fund that. And that actually got people to be much more creative. But it's again being mindful of the payment model itself and what exactly is being paid versus what isn't, I think is helpful. However, from the plan perspective, we won't necessarily know that unless we get feedback. And it gets back to what Eleanor is saying is, how do we build that feedback mechanism and to have those discussions to be able to acknowledge the work.
Okay. We have time, I think, for a couple more questions. So I'm going to throw one more out there and see how we're doing for time. And Eleanor, this one looks like it's going towards you. So given that Pacific Clinics is in multiple counties, are you finding that the implementation experience differs from one county to the next?
Absolutely. I mean, again, because the relationship between health plans and counties vary right across the state. And there are counties that did the whole person care, did HHP. And so those counties tend to be a little bit more advanced, if you will.
Sure.
With the implementation, and there are counties that didn't and are still, trying to figure this out. And the providers are at the end of the counties trying to figure this out. And when I say the counties, it's a relationship between the health plan and the county.
Okay, awesome. I'm going to ask another question. Based on populations of interest, how should the implementation be thought of for future rollouts? And there's an example here. What should it look like for the incarcerated population who are returning to the community? And I know we touched on this, but I'd like to get some specific thoughts here.
So I think part of it really is there's pre-work that has to be done. You can't just say, all right, we're going to go live and magically we're live. And part of the pre-work is understanding these populations of focus. You heard me on my little little rant of like, here are the things we need to pay attention to for those who are criminal justice involved. But that's the same thing for every other population of focus. When we're talking about foster youth, same thing. There's a whole different system of care or supports that we need to then be thinking about. So I think that pre-work to then start thinking, well, who else is involved? How do we get them involved? And how do we think about the design of this? Because as we think about all these pieces, very great goals to start really thinking about these populations that are very challenging. We need to understand, though, that there is a system that already exists that in some way or another somewhat supports, may not support that population. And so how is it that we start engaging sooner rather than later? Because it might be something as basic as, when I say case management, that might mean different to folks, staff in Eleanor's clinics versus when I say it to my teams versus when I say it to probation versus when I say it to a housing coordinator, right? So just even in the way we use terms and learning each other's languages, that I think is part of the pre-work.
Absolutely. I mean, it goes back to implementation science. I mean, that's program installation and having adequate time for that and having this forum where CBOs are a part of it, I cannot underscore enough just that program installation phase. that can take months.
All right, thank you. We'll make this the last question. And just so you know, we will answer all the questions via email because it looks like we're going to get close to time here. How are the CBOs managing payment/invoicing back to the health plans? And what is the biggest challenge in this process?
I guess that's for me. We, again, as an organization that primarily had contracts with the counties, with county and health plans, we built our infrastructure for payments around doing that business. This is a different skill set. To build health plans is a different skill set, is a different process. And we tried, building this on the backs of our staff that built the counties for the services. And we learned, this is where, again, organizations need to be willing to try something, fail fast, and change. But we quickly learned that we couldn't do this. This was something we couldn't build. This is something that we needed to partner with organizations, a third-party biller, and not just have a third-party biller, but really interview that third-party biller to see if they would be partners with us, if they would be a right partner with us, and coming with a payment structure for their services. And so while there are lots of billing organizations out there, it's finding the right one. And so we have a third-party biller.
Perfect. Thank you. So we are just about at time. So I want to thank everyone who attended the webinar. We are very grateful for the time you've taken to spend with us this afternoon or this morning, depending on where you're located. As you can see, the bullet points up here, any of the questions that you submitted, and there was still a number that we didn't have a chance to get to just on the basis of time, we will respond to all of those questions. On behalf of InfoMC and from Catalyst Solutions, if there are any questions, feel free to visit our websites. And if you have any specific questions for either Chris or Eleanor, we have provided their email contact information, so feel free to send them a note. With that said, I am going to wrap up the webinar. So everyone, thank you so much for your time. Have a wonderful day. Thank you.